It is my pleasure to welcome our next speaker, Dr. Eric Bomberg. Dr. Bomberg is an assistant professor and the associate director of research informatics at the University of Minnesota's Center for Pediatric Obesity Medicine. His early research focused on the actions in neuropeptides and their effects on feeding and metabolism, while his later research has largely focused on the use of anti-obesity medications in pediatric obesity. Specifically, Dr. Bomberg's research program focuses on precision medicine approaches for the treatment of pediatric obesity with a goal of discovering person-specific characteristics predicting response to anti-obesity interventions. So thank you for being here today, Dr. Bomberg. I will now turn the time over to you, and just like before, we will have a question and answer session at the end.
Thank you. Can everybody hear me okay? Good, perfect. So I will be focusing a lot of today's topic on pediatrics, but that being said, a lot of what I'm about to talk to is very readily transferable over to the adult side as well. In general, when we look at things like anti-obesity pharmacotherapy and other such things like that, they tend to be approved more often on the adult side first, and then they eventually trickle down to the pediatric side as well too. So a lot of what we're going to see is there's definitely utilization in both sides for sure. And so this is my conflicts of interest. I will definitely be discussing off-label use of medications here, because that's what we do a lot in our clinics. So I first wanted to talk about pediatric obesity in general, so prevalence, trends, and causes. I then wanted to go into understanding the interplay really between obesity and the muscular dystrophies, so both the Duchenne and Becker. And then learn about treatment options for pediatric obesity. So this includes things like weight management clinics that are available, lifestyle modifications, anti-obesity medications, and metabolic and bariatric surgery. So starting out at the beginning. So this is a growth chart that we primarily use in our clinics. This growth chart has been around for about a decade or so. What you will notice on the bottom is you will notice that there's the usual quote-unquote 50th to 95th percentiles that we're all used to looking at. And then the percentiles above that are percentages above the 95th percentile. So the first line is that black line right there is right at the 95th percentile. And then you'll notice that there's a 1/10th above the 95th, a 1/20th above the 95th, and so on and so forth. So pediatric obesity can be defined in 3 different classifications, with class number 1 being the first, the 95th, I guess you can't see it over there, but the 95th to the 1.2 times the 95th percentile, and then 1.2 to 1.4 being class 2 pediatric obesity, and class 3 being 1/40th and above. So that's the usual definitions that we use. As far as the prevalence and trends in adults, this is around 40% of adults living in the U.S. have overweight or obesity right now, and nearly 1 in 5 children, so around 20% right now, of all children living in the U.S. have obesity. Now this class 2 and 3, also known as quote-unquote severe obesity, which is having that body mass index that's 1.2 times the 95th percentile or 120th percentile above the 95th percentile, that is actually the fastest growing category. It has been estimated, and this number is a little old, so I've also seen estimates as high as 8 million children and adolescents living in the U.S. Fall within this category, and that's all children living in the U.S. These are the children that have greatest risk for developing obesity-related health consequences, so things like diabetes, hypertension, sleep apnea, fatty liver disease, etc. And unfortunately, this is also the group in which studies have shown that lifestyle modifications, so just telling somebody to go out and diet and exercise, is generally ineffective. And studies have shown up to 98% of the time that's an ineffective approach by itself. So I always, when we look at causes, I like to break things down into 2 distinct categories. What is known as internal factors, so these are things that are inside of us. So we have this hormone called cortisol, which allows our body to respond to stress, for example. If you have higher levels of cortisol or abnormalities there, that might influence weight status. Genetics, of course, is a big part of it. A lot of obesity is genetically driven. We have the microbiome, which is also involved in this as well too, and things like mood and depression. So these are all our internal factors. But then there's these risk regulators on top of it, and so this is really what's in our environment, right? Socioeconomic status, cultural norms, our built environment, green spaces, walkability, the local food environment. So there's these concepts that are known as food deserts and food swamps, and so availability of healthy food, commercial messaging, parental influences. All of these things build in on each other to control or really to have a role in health behavior. So things like eating and physical activity. And all of this stuff can lead to increased body weight over time. So put another way, it's a lot of different things involved, right? And so we can see things like anything from larger portions, moving walkways, binge eating disorders, less gym class, impulsivity, adverse life experiences, television, antibiotic use, anxiety, sedentary lifestyle, genetics, etc., right? So there's a lot of different potential causes that are in play. So next, I wanted to go into the interplay between obesity and the muscular dystrophies. There is a high susceptibility to developing obesity within the muscular dystrophies. And studies have shown that prevalence of obesity within muscular dystrophies can be as high as 50 to 70%. There's also been studies that have shown that body mass index is typically higher in both those who are treated with steroids and those who are untreated with steroids. And that the body mass index already actually begins to increase before people lose ambulation. And specifically when we're looking at muscular dystrophies, there's a lot of other factors at play that can really help contribute to this even further, unfortunately. One of those being steroid use. So a lot of them, steroids are part of the treatment regimens for a lot of people. Decreased mobility, of course. There's also been studies showing reduced resting and total energy expenditure. And oftentimes when ambulation issues come into play, of course, there's going to be limited opportunities for activity. And then, of course, there's always increased time and financial pressures when dealing with muscular dystrophies itself. It's a life-changing, life-altering experience for sure. Now, in terms of complications that are specific to consider for people with muscular dystrophies, again, there is reduced mobility and physical function with increased falls and fractures, and so that's something that we have to consider as well. There tends to be higher metabolic complications, especially among those who are using steroids or need to use steroids for the condition. And that includes things like high blood pressure, abnormal cholesterol levels, insulin resistance, fatty liver disease, liver fibrosis, insulin resistance on the pathway to diabetes or diabetes. And then also there's worsened lung function and sleep as well too. So these are all specific to consider for muscular dystrophies. Now, in terms of obesity prevention strategy, right, we always want to talk about prevention and management. So it has been recommended in terms of prevention strategies to introduce this concept at 4 different time points. And those 4 different time points are at the diagnosis of the muscular dystrophy, at the time of steroid initiation, obviously, if that is applicable, at the time of loss of mobility or decreased mobility, and any time that there has been a significant increase in body mass index. And really what this should include, so prevention strategies should include, these are all based upon recommendations that have been published, but they should include facilitating a healthy home food environment in consultation with a dietitian, counseling on sleep, hygiene, and screen time, psychosocial assessments for both parents and caregivers, and approaches to physical activity, because that's going to be different, and I believe that there's a talk later on today about that. And then the 5th I would at least consider is perhaps weight management referral as well too, which we're going to talk about in a second. So in terms of previous interventions in muscular dystrophy, overall there has been very few studies in prevention and management. There's been a couple of studies out there that have shown that family-based interventions have shown at least short-term modest BMI or body mass index reductions. There's been only a few studies that I could find that have looked at medication trials. And so there is a medication, and we're going to talk a fair more about what some of these medications are in just a little bit here. But for example, there was a study showing among 42 people, randomized control trial, who received metformin, an average weight loss of about 5 pounds over 6 months. Topiramate, there's been a couple of case reports about this medication, which we'll talk about in a second. And then in terms of omega-3 fatty acids, there was a smaller randomized control trial that showed that it improved insulin resistance after 6 months. That's about it. So not too much research has been done within this area. And furthermore, there are no specific disease-specific evidence-based management guidelines. So we definitely do have guidelines for both adult obesity management and pediatric obesity management that are out there by several organizations. But in terms of disease-specific, so muscular dystrophy, for example, specific guidelines, there are none. But there are lines in all of these that talk about adapting them. The current standard care guidelines that are out there, there's at least guidelines, or there's at least within the guidelines, these are things that should be adapted. So finally, biggest part is I wanted to talk about treatment options for pediatric obesity, and you'll see that there's a fair amount in terms of translation over to the adult side as well too. So this includes things like weight management clinics, lifestyle modification, anti-obesity medications, and metabolic and bariatric surgery. So first, here at the University of Minnesota, we actually have one of the largest pediatric weight management programs in the country, and I'm fairly certain we're that way as well too on the adult side. So on our pediatric side, we actually see patients almost every day of the week. We have 4 different clinics with about 8 different providers. We actually have a pediatric obesity fellowship program here as well too, where we train people to do pediatric weight management for a living. So we're located at Riverside, which is right across the river from here. We have one at Maple Grove, we have one at Woodbury, and we have one at Burnsville. On the adult side, we have a clinic that is located at the, theoretically located at the Clinics and Surgery Center, which is right up the street over here. But that being said, we do a lot of things virtually ever since COVID as well too. So that's why I say theoretically is located there. So we do have resources that are available. So what are some things that we may do in a weight management visit? One of the things, and these are all general recommendations overall, but I think that we stick to these fairly well in our clinics. So one of the things that's been recommended is to do annual and symptom-based screening for conditions associated with obesity. And so that includes things like screening and looking for things like diabetes or high blood pressure, high cholesterol, sleep apnea, non-alcoholic fatty liver disease, and depression. You next want to look at identifying the contributing factors. And so sleep disorders, disordered eating, socioeconomic status. And we do know that within muscular dystrophies, sleep disorders are higher for sure. We also do want to look at medications that somebody may be on that may be associated with weight gain. Sometimes we can do something about those medications, and sometimes we just know that that's part of the treatment. But that includes things like steroids and insulin, for example, but there's others as well too. Next, you want to look at screening for secondary causes of obesity. And what I mean by secondary causes, these are in general fairly rare, but these include things like there are specific gene mutations. So for example, there's something called leptin deficiency, which is caused by a mutation in the leptin gene. And that would be one specific cause of what is known as genetically driven or monogenic obesity, for example. There's also neurological causes, so things like brain injury, brain radiation, etc. And then in terms of the quote-unquote endocrine causes, although I would argue that they're all endocrine causes because all of obesity is related to hormones and neurotransmitters and other things. But the ones that people generally think about are things like hypothyroidism, so having a bad-acting thyroid, having a growth hormone deficiency, and having something called Cushing's disease, which is where you may make too much of a hormone called cortisol. These are all very, very rare. Especially these endocrine causes are all very, very rare. And then you want to develop a treatment plan. And the treatment plan needs to be intensive, it needs to be age appropriate, it needs to be culturally sensitive, and it needs to be family centered. So these are the things that I generally do at any weight management clinic, and I see both pediatrics and adults myself personally. But I always try to establish at every visit food goals, activity goals, talk about medications, and then sometimes there's other things as well too, whether it's referrals for a sleep study, psychology, physical or occupational therapy if people don't have those already, and other things as well. And all of this stuff is done through shared decision making. I think that that's a very, very, very important concept. So in terms of lifestyle modifications, now this is really the background of all treatments, and everything else that we do is on top of this, and so I just wanted to briefly go over this. So what are some of the things that have been recommended? Sure, it's been recommended to decrease fast food, added table sugar, and high fructose corn syrup. It's been recommended to decrease high fat, high sodium, or processed foods. It's been recommended to reduce saturated dietary intake for kids who are 2 and above, or adults. Consume the whole fruit rather than the fruit juice. Eliminate sugar-sweetened beverages. Educate on portion control. Follow the USDA recommendations for intake of fiber, fruits, and vegetables. Timely, regular meals, so having, for example, breakfast, lunch, and dinner as opposed to I'm going to have a little snack here, a little snack here, a little snack here, a little snack here. And then recognizing what somebody's eating cues may be, so whether it's eating out of boredom or stress or loneliness or screen times or hunger, binge eating tendencies or others. And then the last one is not evidence-based, but has definitely been recommended as well too, which is encouraging single portion packaging and improved food labeling. This is a slide that I like to show a fair amount. This is comparing 20 ounces of Tropicana with 20 ounces of Coke. And as you will see, the Tropicana actually has more calories than the Coke and basically the same amount of sugar. So in terms of lifestyle, or in terms of exercise principles, this is the general recommendations. Overall, the general recommendations is there is a goal for 60 minutes of moderate to vigorous physical activity a day. That does not need to be done in one session. And one of the things that I often do in clinic is I provide what is known as kind of a written prescription. So under activity goals, we will shoot to do this for this amount of times per week, for this amount of minutes per time, for example. And it's also recommended to limit non-academic screen time. And again, importance of shared decision making, and within muscular dystrophy, there's a lot of specific considerations as well too. So let's talk about medications, right? What is out there? So these are the current 5 medications that have now been approved for use in youth. And these are one called phentermine, one called orlistat, one called liraglutide 3.0 milligrams daily, also known as Saxenda, one called phentermine topiramate put together, which is called Qsymia, and then one called semaglutide 2.4 milligrams daily, and I realized I made a mistake right there. That is not Mounjaro, that is one called Wegovy, so that's a mistake, I'll have to change. The bottom line is that a lot of these medications are also approved on the adult side as well too. A lot of these have really come in play within the last year or so, or within the last 2 years. So you'll notice 2021 with the Wegovy, that's mistakenly marked as Mounjaro right down there. That one coming in actually in December of 2022 for approval for pediatrics. And you will notice also too that one, and these are within the studies itself, is the largest bang for the buck nowadays in terms of average weight loss. So that one, the studies have shown an average weight loss of around 16% after 68 weeks, compared to a gain of 0.6. So fairly significant territory with these newer ones. Now, there are other options that are currently out there in youth as well too, that are currently in studies. So for example, I had just shown that this first medication up here, Saxenda, was approved up in 12 and above, so now they're doing studies down to the age of 6. I had just showed you that semaglutide 2.4 milligrams, or Wegovy, was approved up to the age of 12 and above. Now they're doing studies also down to the age of 6. And then there's another one called tirzepatide. That one is Mounjaro, which combines, which is what is known as a glucagon-like peptide 1 receptor agonist, and I'll talk about that in a second, what that is. And it combines with another hormone, and their studies, that one was approved for use in adults, or is close to being approved for use for adults for treatment of weight management. And that one is currently in studies right now down to the age of 12. There are still others in the pipeline as well, too. So this is the first two right here are oral. These are studies in adults. And then there's another one called retatrutide, which is somewhat similar to some of the others that we have seen, but with something else called glucagon involved with it as well, too. These are all trials in adults, and especially when you look at that third one, and you see that average weight loss is 24%. Within 48 weeks. Now we're getting up into really, really significant numbers. And so these are the ones that are currently in studies in adults. And as is almost always the case, things start in adults and then they trickle down to kids. So again, these are the ones that are currently approved for adults right now, with, again, Wegovy being the biggest bang for your buck. But that being said, there are a lot of different potential possibilities in terms of medications that we could consider. So for example, orlistat. There is phentermine, which is a stimulant medication. There is one called topiramate that we use a fair amount. There is, again, that combination of phentermine and topiramate, which can either be prescribed as the medication itself, the once-a-day medication itself, or as the two components of that medication separately, which are generic and readily available. There are others in this class of GLP-1 agonists that are out there. There is metformin. There is one called naltrexone, which I'll talk about in a second. There's a combination medication called naltrexone and bupropion, which is approved for adults. There is one called tirzepatide that I had mentioned before. And then we do also use a fair amount of stimulant medications. One in specific is called Vyvanse, which is actually FDA approved for the treatment of binge eating disorder in adults, or other ADHD stimulant medications. So when we're thinking about medication options, these are the things that I like to consider. What is the mechanism of action? What is the side effect profile? Are there any contraindications? How does a medication fit with what somebody's eating phenotypes may look like? And I'll talk about that in 1 second. Are there any other comorbidities that this medication may be able to help with? Cost access issues are a huge issue within our field for sure. And then again, patient-family preference, right? This is shared decision making. So briefly, in terms of mechanism of action, the first one out there is that's listed up here is one called orlistat that I had mentioned a couple of times. It's not a very effective medication, rarely is used, and the bottom line is it causes you to poop out fat. And so people do not like this medication. It's not very effective. It only works if you eat a lot of high fatty food. And if you don't have that side effect of pooping out fat, then it's probably not working for you. So that's the first one. The second one is phentermine and topiramate. I had mentioned that one before too. So phentermine as a stimulant medication works on an area of the brain called the hypothalamus to really reduce levels of hunger. And in terms of topiramate, to this day, we're still not entirely sure how topiramate works, but we believe that it works on a couple of signals up in the brain. So dopamine is one of those, and one called GABA, and another one called glutamate. And it really seems to work on those signals to quiet down signals related to eating, reduce binge eating tendencies, and reduce cravings for foods. In terms of naltrexone and bupropion, the bupropion part, we're not entirely sure how that works. But in terms of the naltrexone part, this is a blocker of opiates. So it's an opiate receptor blocker. And so this tends to work This tends to work on craving and reward pathways for food. So I really enjoy food and eating. I really like carbohydrates. This tends to work on those pathways. And then there is this last class that I talked probably the most about, which is these GLP-1 or glucagon-like peptide-1 receptor agonists. The main thing that these things do is these things work on the hypothalamus to improve the feeling of fullness. So that's one of the major things that they do. They also delay the rate that food leaves your stomach. So in other words, if you eat something and that something sits in your stomach for a longer period of time, it then sends a signal up to your brain or your hypothalamus telling you that you're fuller for longer. This keeps food in the stomach for a longer period of time, which will then bring that signal up for a longer period of time and make you feel fuller for longer. Now, in terms of side effects, we're not going to go over this, obviously. This is just to show you that, yes, we do consider side effects. We do consider contraindications. On the pediatric side, there's obviously fewer contraindications that we generally consider on a regular, everyday basis than there are on the adult side. So, for example, I wouldn't want to give a stimulant to somebody who had a history of, needing a heart transplant, for example. That might not be a great idea. But this is just to let people know that obviously there are going to be side effects to every medication. Most of these medications are tolerated very, very well. There's certainly contraindications that we will consider as well too, and obviously we wouldn't give them if somebody had a hard contraindication to something, but just to show you that that stuff is out there. Next, I had kind of briefly mentioned about these eating phenotypes, and this is one of the things that we tend to do a fair amount to kind of help drive our choices of medications, because you really want to try to fit a medication to whatever the symptom happens to be. And so, for example, if you have some of these are easier said than others, but these are the proposed eating phenotypes that are out there. So night eating, having poor fullness, having strong hunger, having emotional eating, binge eating, impulsive eating, and reward-based eating. And so if you're thinking about various different things you might want to do, if you have poor fullness, a GLP-1 agonist might be a good idea for you. If you have strong hunger, perhaps a stimulant medication might be a better option. If you have binge eating, there is Vyvanse is a medication that's been FDA approved for binge eating, for example. If you have reward eating, perhaps naltrexone. So these are all just, these are both used in terms of our plans for lifestyle modifications and also in terms of our plans for medication choices. Again, you also want to consider things like comorbidities as well too. So if somebody has type 2 diabetes, you might want to consider using what's known as one of those GLP-1 agonists, because those are approved for the use of type 2 diabetes originally. If you have type 2 diabetes and high blood pressure, there's some medications to treat blood pressure that are better than others. If you have, bupropion, for example, is an antidepressant, and so if you had depression, that might be an option that, you kind of kill two birds with one stone, essentially. And then in terms of the use of atypical antipsychotics, these three medications that are listed down here all have studies that have shown that they can help curb weight gain from the use of atypical antipsychotics. So now, one thing that I think is very important is that many insurances require prior authorizations for a lot of these medications, and many will not approve off-label use of medications. And many of these can be very, very expensive. And so these GLP-1 agonists, for example, are around $1,000 or $1,500 a month out of pocket. So there are different things that we can do. So there's things like manufacturer websites, shopping pharmacies, or using GoodRx. You could split the pills if you're able to. One of the things that we commonly do is, instead of prescribing one of those combo pills that we had mentioned before, we might prescribe the two components of it separately, just because both of those components for each of the combination medications that we talked about have been generic, and they're readily available, and they've been that way for many years now. And then again, you want to discuss the benefits and risks of medications. You want to discuss their status as non-FDA approved, if that happens to be the case for that particular medication. And again, shared decision making. Very briefly, I just wanted to mention that there are recommendations or guidelines out there for metabolic and bariatric surgery. And these were recently, there's been a number of different organizations to have recommendations out there. This is from the American Academy of Pediatrics that came out just this year. So there are recommendations, as you can see, for both class 2 and for class 3 obesity, and other comorbid conditions that fit within that recommendation as well, too. So we won't go through these in detail, but just to know that that is something else, that is another tool that we have at our disposal. Finally, I kind of want to end on a role for precision medicine. So precision medicine is an approach, an emerging approach for disease treatment and prevention that accounts for an individual's variabilities in genes, environment, and lifestyle. And it's really about identifying and characterizing the sources of variability in response. And so the goal is, and we're working towards this goal, and this is actually the major part of my research program, is to try to develop for each individual person that we're seeing, what is the right treatment for that person, for the right person at that right time. And I finally wanted to leave with this. There's a lot of misconceptions out there about obesity. This is something that, this is caused by bad diet. This is caused by decreased physical activity. This is people's faults, right? This is a disease of choice. And that is definitely not the case, right? I think it's very, very important to deal with things like weight bias, weight stigmatization, and this is the definition of obesity as a chronic disease from the Obesity Society itself. So obesity is a multi-causal chronic disease recognized across the lifestyle, resulting from long-term positive energy balance with development of excess adiposity that over time leads to structural abnormalities, physical derangements, and functional impairments. The disease of obesity increases the risk of developing other chronic diseases and associated with premature mortality. As with other chronic diseases, obesity is distinguished by multiple phenotypes, clinical presentations, and treatment responses. So it is a chronic disease. So in summary, obesity affects around 1 in 5 children and adolescents in the US, with that severe obesity category that I had talked about being the fastest growing category. There is certainly a high prevalence in the muscular dystrophy, so anywhere between 50 and 70%. Again, high susceptibility in muscular dystrophy, and there's certainly additional factors that we need to consider, so things like decreased mobility, higher metabolic complications, higher sleep disordered breathing, and there is certainly an importance to prevention and management, especially within muscular dystrophies. You want to consider the multifactorial causes when developing individualized treatment plans, and treatment plans may include things like weight management clinic referrals, where we do a lot of this stuff, or lifestyle modifications, anti-obesity medications, and metabolic bariatric surgery. And so with that, I will take questions.